Okay, today we'll see about principle of preoperative and operative surgery. Okay, in that first we'll see about principles, assessments, system approaches, what are the systems, how to deal with the systems, and that ERAS protocol, antibiotic protocols and all, and how is the operating room should be, and what are the surgical devices, energy sources, status, and the potential causes of intraoperative instability. Okay, going hypothermic gas, embolus, myocardial infarction, hemorrhage. So everything you will see. Okay, so first we will come. They are telling that one fact is they are telling that the World Society Emergency Surgery created the timing of acute care surgery in 2003. There is no need, which it subdivides urgent cases. So what is mean urgent cases? Urgent cases into those with an ideal time to surgery falling between immediate to within 48 hours from the diagnosis. Okay, but 48 hours from the diagnosis is called urgent cases. Okay, okay. This is very high topic. Okay, you can expect that at least 2 questions. Okay, from this semester chapter itself. Okay. So risk assessment. So risk assessment, you already know ASA physical status. Okay, American Society of Anesthesiologists physical status 1, 2, 3, 4, 5. Okay, 1 is healthy, 2 is mild, 3 is severe systemic disease, and 4 is severe systemic disease that is constant threat to the life, and 5 is moribund patient, and which is who is not expected to survive without life support. So here they are telling that this 1 and 2 are low risk. Okay, 2 is intermediate risk. 4 and 5 are high risk. So here they are telling that the 5E associated with the nearly 20% likelihood of yearly postoperative mortality. This 20% is very important. So next we will go to what are the risk of death. Okay, risk of death in case of very low risk patients, very low risk OPD procedures. Okay, the risk of death is around 1:50,000. Conversely, in high risk operations, okay, for that exceeding 20%. So remember 20. Okay, 5 ASA 5E also 20%. Okay, likelihood of mortality, and high risk operations 20%. Okay, then they are telling that. Okay, then various tools have been quantify the operative risk in the pre-operative settings. Okay, the tools they are divided into 3 groups: categorical scales, risk scores, and the prediction models. Okay, the category example for categorical scales is the ASA classification. Okay, and the example for the risk score is MELD score. Okay, so next is the risk prediction models. That it comes into a model that accounts for patient level risk factor to generate estimated likelihood of multiple surgical outcomes. Okay, among the most commonly used cited example of surgical risk score is ASCS NSQIP surgical risk calculator. Okay, so ACS NSQIP SRC. This is your MCQ. Most commonly used surgical risk score. Okay. So okay, we'll come to later what is that score. Okay, before that their surgical we already told low risk, intermediate, high risk. So how to define this low risk, high risk, intermediate risk based upon the operation type of operation? Very important table. So see, the low risk means risk mortality rate is less than 10%, and intermediate risk is 1 to 5%, and the high risk is more than 5%. Okay, so here all surgeries will come, all minor surgeries will come, except you can see thyroid is a big surgery. It will come in low risk. Okay, remember like that. Okay, so thyroid is a big surgery, endocrine surgery, but it comes still in the low risk. Okay, and other intermediate risk, you have to see intraperitoneal, what you are doing routine intraperitoneal splenectomy, hiatal hernia repair. Okay, corrected sympathetics, symptomatic. Peripheral arterial angioplasty, endovascular aneurysm repair, head and neck, neurological, and orthopedic such as hip and spine surgery, urological, gynecological, major surgeries. So minor will come in the low risk, and major will come in the intermediate risk. So renal transplant. In the transplant, only renal transplant will come in the intermediate. This is your different point. Okay. Other transplant, such as a liver transplant, and all will come under the high risk. Okay. So in that among the transplant, renal transplant only will come in the middle intermediate risk. And intrathoracic non-major. Okay, intrathoracic non-major. Major will come in the high risk. Okay, intrathoracic non-major. So remember like this. So high risk patient, any vascular surgeries, Here you see angioplasty, aneurysm repair. These are all interventional procedures. Okay. When you are going for any open procedures like aortic and major vascular surgery, okay, then it will come into the high risk. Okay. So like that, you have to remember when it touches the duodenal pancreatic movements like that, the liver resection, esophagectomy, perforated bowel, adrenal resection, total cystectomy, pneumonectomy, and the pulmonary or liver transplant. So liver and pulmonary transplant and all high risk. Once I am telling, see, breast and thyroid will come under low risk, intermediate risk renal transplant, and minor procedures, example angioplasty like that, and high risk procedures, all big procedures will come. Okay, among that you have to see about pulmonary or renal transplant is come under high risk. Okay, pulmonary and liver transplant. Renal transplant is common intermediate risk. You have to know splenectomy. Splenectomy, we thought that it is a big procedure. It's not a big procedure. It is comes under intermediate procedure. Okay. So this is expected questions. Then we will go to informed consent. Okay, informed consent. Okay, then go to informed consent. In the informed consent, what are the consent discussions should include? The consent discussion should include the disease diagnosis. Okay, and the proposed procedures and the procedure related risk, rightly success of the procedure and mental capacity of the patient and alternate treatment options. Okay. So one of the most challenging impediments to informed consent is the knowledge gap between the surgeon and the patient. Okay. So surgeon and the patient knowledge gap is one of the challenging impediments of informed consent. I already told ACCS, NCQIP. Okay. Variables used in the colon specific under the universal surgical risk calculator. Okay. So these are the various variables they are using. Okay, this actually is not an important one only. Okay, no need to go through it. They are still telling that variables. Every variable will come. Okay, so they are telling for colonic specific and universal for common procedures. Okay, you have to remember everything. How to do this one? For colonic purpose, if it is there, they are asking about age, group, sex, functional status, emergency cases, ASA, steroid use for chronic infection, ascites within 30 days preoperatively. Okay, and systemic sepsis within 48 hours preoperatively. Okay, and ventilated dependent or disseminated diabetes, hypertension, cardiac events, congestive heart failure in 30 days preoperatively, and dyspnea and current smoker within 1 year. Okay, so remember this 4 things very important. Ascites within 30 days, systemic sepsis within 48 hours, and congestive cardiac failure within 30 days. And the current smoker within 1 year. Okay, they can send the value among the variables of ACS, NCQIP. Okay, and the rest of the underlal is common only. Dialysis, renal failure, DMI. Okay, and the colonic surgery group, indication for colon surgery. Okay. Just remember this for colon specific, and suppose universal specific is universal is coming, then that colon specific group won't come, and the indication for colon surgery they won't come in the variable. The rest of the things will come. So just remember this 4 things. Okay, ascites within 30 days preoperatively, and the congestive cardiac failure also 30 days preoperatively. And the systemic sepsis is within 48 hours, and the current smoker within 1 year. Okay, this 4 things you have to remember among the variables of ACCS, NCQIP. So here comes your another table, ACES, NCQIP, Universal Surgical Risk Calculator, reported outcome measures. Okay, so what are the report outcome measures? They will ask. Okay. This is universal. Okay, this is universal surgical risk calculator report outcomes. So here I put down mnemonic. If it is feasible, you can remember also. So here ABCD B1 come. Okay, so ABCD PQ1 come. PRST UV like that I remember. Okay, D3 R3 S3. Okay, so first A. So here A is for any complication. Okay, any complication. Then C cardiac complication. Then D3. So D3 means first D is your death. Second is discharge to the nursing or rehabilitation. Okay. More D. And the P. Let's see the P. P is pneumonia. And the R3 renal failure, readmission, return to the. Okay. And then it comes your S3. S3 is serious complication, SSI, and sepsis. Okay. Then UV, urinary tract infection, venous thromboembolism. Just remember like that. Okay. Here is B is 2 only, not B3. Okay. B is 2 only. Just remember. And this they can ask. Okay. Current table. Then comes your here assessment of, we are in the topic of subtopic of assessment of geriatric surgical patients. So in the geriatric surgical patients, mainly they ask to assess the what are things they have to assess. Okay, checklist or a checklist for preoperative assessment of geriatric surgical patients. So you have to see about the cognitive ability, capacity, depression status, delirium, cardiac evaluation, pulmonary, functional status, falls, frailty score, nutritional status, medication history, polypharmacy, treatment goals, expectations, diagnostic test. So everything you have to ask when the patient coming in the preoperatively. First, we'll go to the cognitive impairment delirium. So cognitive impairment delirium, that is that nearly 1 in 5 elderly patients has dementia cognitive impairment. Okay. So how to assess the cognitive impairment? By using Mini-Cox scale. This is a main MCQ. By using Mini-Cox scale. Okay, Mini-Cox scale. So how to interpret the Mini-Cox scale? So you have to use, they are telling you a term called 3-item recall and clock draw. A 3-item recall and clock draw. 2 methods they are using. Okay. Among that, first what they are doing is, first they tell the patient, get the patient attention and then say. So they will tell the patient 3 words, banana, sunrise, chair, like that. They tell the student and tell them to repeat it. Okay. They give 3 chances. Okay. If the patient not able to repeat within the 3 chances, then they will go to the next step. Next step is say all the following phrases in the order indicated. Okay. That means that they are telling that they are going to draw a clock. Ask them to draw a clock and ask them to put the numbers 1, 2 like this. And tell them to mark on exactly on 11:10 or 11:30 like that. Okay. Like that, you have to tell them to mark. If they mark it correctly, it is good. Okay. Like that, they're giving some tests. There is no need to read very deep depth inside. You have to know about Mini-Cox and the 3-item recall and the clock draw. That word is important. Okay. So if they again they wouldn't tell this thing, then they will again ask the previous one. What we had told before, that also they ask. That is the 3 things they are telling. So main is 3-item recall and the clock draw they have to do. So based upon this, they are putting some scores. Okay. This and all no need to remember. Okay. This everything neurology topics. Okay. Just to remember this thing. Total score comes under 0, 1, 2 suggests possible impairment. 3, 4. If it comes under 3, 4 or 5, this is suggests no impairment. Okay. It is very easy only if you want to know scores, how to interpret. They can ask also. They can ask in like that any some case scenario also they can give. The patient is giving and 1 point telling like that. If they ask, you should be ready to answer that one. So for that, the 3-item recall, they are giving 0 to 3 points. So 1 point for each correct word. And the clock draw, they are giving 0 to 2 points. 0 point for abnormal clock. The drawing itself abnormal, and it is 0. Okay. And the 2 points for normal clock. Okay. That's it. So based upon this, we have to add this point and we have to put a score. Okay. So maximum score will come under, minimum score will come under 0 and maximum score will come under 5. So 0, 1, 2 is possible impairment and 3, 4, 5 is no impairment. Okay. Understood?
Yes, yes.
So,
yes
okay,
yes.
that's it. Then risk factor for post-operative delirium, I no need to remember. It's everything you already know. Just remember age greater than 65. That term is important. The rest and all thing at all you have to know. Even that urinary retention also can cause delirium. Okay. This is already Bailey having some good chart. Okay. We will see in the Bailey. Next comes your usage of beta blockers, perioperative beta blockers. I will give in the slide. On slide is there. I will tell in the slide. Next comes your. So here they are on just they are telling that timed up and go tool. Okay, which measures the functional mobility, of the patient. Okay, so this is called tug tool. You have to know about this tug tool. So what is tug tool? You have to know. So this is a timed up and go test. Nothing very easy. You have to tell the patient first. The patient will be sit. You have to tell the patient to stand up first and walk. Tell him to walk for 3 meters. And you have to tell him to turn around this blocker. Okay, and again walk 3 meters and ask them to sit down. Very simple test. And the patient should do this within 10 seconds. It is normal. Okay, that is tug tool. So suppose the patient is taking time more than 20 seconds. It is associated with the 50% risk of major complications among older than 70 and compared to 14% of the patient with a tug less than 20 seconds. Okay. If it is, normally it should come within 10 seconds. If it takes more than 20 seconds, the risk is 50%, and if compared to 14%, when the risk is less, the takt time is less than 20 seconds. Okay. This is the only point. Then system approaches to preoperative counseling, cardiovascular system. So cardiovascular system, they are telling that, okay, patient undergoing low risk operation do not require any preoperative cardiac testing. Finished. Low risk operation, no need to do any preoperative cardiac testing. So when comes your other testing? So suppose you are going for vascular surgery. Okay, vascular surgery is highest risk category. Vascular surgery comes under highest risk category. Okay, so it's associated with morbidity rates of greater than 5%. Okay, so examples like aortic peripheral vascular disease and endovascular surgery is included in this category. So see, endovascular surgery also comes under highest risk category. It's greater than 5%. Here they are telling, okay, according to this cardiac problem, they're telling endovascular surgery is included in this category. Okay, so the intermediate risk, so same, so previously is 1 to 5%, lower risk to 5%, same thing only. So how to assess this cardiac mortality and the cardiac risk? Using this reversed cardiac risk index, very, very important. Reversed cardiac risk index, RCRI. Okay, very expected MCQ. So it's having 6 points. Okay, so high risk type of surgery, ischemic heart disease, history of congestive heart failure, history of cerebral vascular disease, insulin therapy for diabetes, and a preoperative created more than 2 milligram. Okay, 2 milligram per deciliter. So how to predict the risk? So if the patient having 0, 1, 2, 3 or more factors assigned to class 1, class 2, class 3, class 4. Okay, so if the score is 0, then it is 1, this class 1, and the score is 1, this is 2. Okay, like that. 3, and more than 2 is 4. The 4 is severe. So they are telling that ASA, AHA guidance are using the ACS NCQIP risk calculator as an alternative to the RCRI. So what are the alternative to RCRI is? Our previously we saw ACS NCQIP risk calculation. So next they are coming into the one term is called a metabolic equivalent test. Okay, metabolic equivalence. Okay, so METs you have to know about the concept of the METs. Okay, so the MET is metabolic equivalence of task. Okay, so whatever activities we are doing is having certain METs. Okay, simply sitting is 1 MET. Okay, climbing is 4 MET. Okay, like that telling that work in the MET is okay. So it is very much explained in Bailey. So here I will do the little bit things. So here you have to see the ACC guidelines recommend that patients with the MET greater than 4 without symptoms of cardiac disease proceed with the elective or urgent operation. So they are expecting at least METs greater than 4. Okay, without symptom of cardiac disease. Remember this term. For any elective or urgent operations. Okay, for any patient undergoing a low risk operation, regardless of clinical risk factors, even with the functional capacity less than 4 METs, okay, have low risk cardiac complications and does not require further testing. Okay. So if any patient undergoing a low risk operation, regardless of clinical risk factors, even with the functional capacity less than 4 METs, have a low risk for cardiac complication, does not require further testing. So already the patient is having low risk operation only. Okay. For that patient, less than 4 MET is not going to do anything. Okay. Okay. So you see exercise testing with the cardiac imaging may be indicated for patients with elevated risk and poor. That means less than 4 METs and unknown functional capacity. Okay. Okay, the risk should when you have to go to a cardiac imaging, the risk also should be more. The surgery risk also should be more, and the METs also should be poor. Okay, like this 4 METs with increased risk or unknown functional capacity. The patient have 3 or more risk factors. Then you have to go for cardiac imaging. Here you see the patient having low risk operation. Okay, low risk operation, they didn't see about the MET also. MET is not a considerable factor, so they are not going for any testing. Okay. So terms in the other high risk cardiac patients, what are some other high risk cardiac patients? Which causes increased risk of death. Okay. risk factors for increasing the risk of death. So left-sided heart failure, number 1. Okay, number 2 is right-sided heart failure. Number 3 is pulmonary hypertension, which is more than 25 mm SCG, and aortic stenosis, where aortic valve area less than 1 centimeter square. Okay.
Repeat once.
So what are the risk factors for increased risk of, these are the factors which causes increased risk of death. Okay, increased risk of death. Simply you have to say these are high risk cardiac patients. Okay.
Okay.
Which leads to death. These 4 patients: left-sided heart disease, right-sided heart disease, pulmonary hypertension, and aortic stenosis. The value is important. The pulmonary hypertension more than 25, and the aortic stenosis, aortic valve area less than 1 centimeter square. Okay.
And the stent, drug-eluting stents days, December.
Yeah, I will tell that. So these are about some patients already having some pulmonary revascularization, having some stent. So they are planned for some elective surgeries. So how much time they have to be delayed? That is MCQ, very important MCQ. So for the patient considering non-elective, elective non-cardiac surgery after recent coronary vascularization should be delayed a minimum of 14 days for balloon angioplasty. So 14 days for balloon angioplasty and 30 days for bare metal stent. Okay. Balloon 14 days, bare metal stent 30 days, and 1 year if they have drug-eluting stent. Okay. Drug-eluting stent due to the need of dual antibiotic therapy. The operation with the incursion of the dual antibiotics is considered after. Suppose they didn't take a proper anti-dual therapy, they should be considered after 180 days. Okay. And any operation with the interruption of dual antibiotic therapy could be considered after 180 days following DES placement. The risk of further surgical delay exceeds the risk of stent thrombosis and ischemia. Okay. So just remember these terms. Okay. Actually, 1 year is important, but nowadays they are doing it 180 days for DES double drug-eluting stent. Okay. Ideally 1 year, but it should be done in 6 months. This is our MCQ. Okay. So balloon angioplasty 14 days. Okay, bare metal stent 30 days, and 180 days for drug-eluting stent. But ideally 1 year. Okay. You see the options. Ideally, if term comes, then 1 year. Simply they're asking, you can tell about 180 days. Okay. So this flow chart is having no significance. Okay. Let's go to the cardiac system. Please, let's go to the pulmonary system. Okay, let's go to the pulmonary system. The pulmonary system, they're telling that 6% post-operative pulmonary complication occurring approximately 6%. Okay, here they're having one study. Okay, Ariscard study. That comes to study later. And the Ariscard index also there. I'll tell what is Ariscard index. So broadly, ACP's guidelines indicate that the patient-related risk factor or for post-operative pulmonary complications include. Is very important. Okay, risk factor associated with post-operative pulmonary complications. Age greater than 50, ASA class 2 or above, functional dependence, hyperalbuminemia, which is less than 3.5 grams per deciliter, and COPD and heart failure. Okay, so a failure, especially when associated with the pulmonary hypertension, is a considerable predictor. Okay, it's a considerable predictor. So smoking cessation, how much time smoking? How many days smoking should be cessation? Cessation of smoking at least 4 weeks. Okay. That means 1 month prior to surgery, the patient should stop smoking for better outcome. Okay. So when the patient did routine chest radiography, next question. Routine chest radiography may be indicated in patient greater than 50 years of age who are undergoing high risk surgery. Okay. They're seeing about pulmonary complications. Okay. This is not the routine chest X-ray. Especially pulmonary complication, you have to go more than 50 years. You have to take routine chest radiography. What are the various preventive indexes for pulmonary complication? The most frequently used are Arousula index. Okay, Arousula index, very important. This they can ask. Okay, only 3 are there. They can give one more indicator. They can ask. Okay, what is Arousula index? And this Ariscat index. That is Gupta respiratory failures calculator. Okay, very important. Among that, they are using this Ariscat. That Ariscat index is the simplest to use. Okay, simplest to use, featuring 7 really available preoperative predictors in a simple score system. So what is Ariscott risk score system? So what are the 7 variables? That is MCQ. Number 1 is age. Number 2 is preoperative SpO2. Number 3 is respiratory infection in the last month. 4 is preoperative anemia less than 10 gram. 5 is surgical incision. Number 6 is duration of surgery. Number 7 is emergency procedure or not, whether it is emergency procedure or not. So this you have to remember, have to remember. Very, 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 very important. Ariscott risk score. Okay, for detect the postoperative pulmonary and complications risk. Okay. So next they are telling about Arizula index. So what is the one more thing I have to remember? What is the disadvantage of this Ariscott index? Is it overestimate postoperative complication rate, as its complication definition includes minor morbidities such as small radiographic efficiency and bronchospasm BC. Okay, it may overestimate. Even minor comorbidities also you will overestimate. That is a problem. So what is Arizula index is derived from the veteran population, especially targets postoperative respiratory failure. Okay, so it includes more than 12 factors. That our Ariscott index having more than 7 factors, and here it indicates more than 12 factors. And the Gupta score developed a risk factor using NCIS, ACS, NCQ, IP only. Okay, of postoperative respiratory failure, pneumonia. Okay, so what is high prevalence of OSA? Where is high prevalence of OSA? High prevalence of OSA is older age, obesity, male sex. So remember, older age, obesity, male sex. This is a risk of OSA. And what is a questionnaire used for OSA is stop bank. And very, very important. Stop bank questionnaire. Stop bank questionnaire is for OSA. So what are the stop banks? Stop bank having 8 variables. Okay, 8 scoring tools. Okay. See, S, T, O, P, B, A in the stop bank. So S is your snoring, and T is your tiredness. Okay, O is observation of stopped breathing or interrupted breathing during sleep. Okay, so anyone should observe. That is important. Okay, it's not simply stop breathing. Anyone should observe that you are stopped the breathing. Okay, you could not obviously observe, not able to observe because you are already sleeping. So any who are sleeping with you should observe that you are stopped the breathing. That is one point. And a high blood pressure. So B is pressure, stop blood pressure. And what is bank? So B is BMI more than 35, and the age is 50. Neck diameter more than 40, and the male gender. Gender is G. Okay. This is your stop bank. Okay. Stop bank. This can ask us MCQ. Okay. So what is so S is for snoring, and T is for tiredness, and O is for observation of stopped breathing and increased blood pressure, and B is your BMI more than 35, age is greater than 30, and neck diameter greater than 40 centimeter, and the male gender. Okay. This they cannot stop blank. And the patient requiring urgent or emergent operation are managed for OAC in the post-operative setting. So what is obesity hyperinflation syndrome? Okay, the combination of BMI greater than 30 with the PaCO2 greater than 45 are indicative of hypercapnia. There is no strict guidelines for arterial gas measurement of obese patient, although the high risk of hyperventilation are patients with the BMI exceeding 50. The BMI exceeding 50. Okay. What are the renal system? What are the renal systems they're telling? So let's come to the renal system. So renal system, they're telling that patient with the stage, okay, 1 to 2 chronic renal failure insufficiency and functional capacity greater than 4 NETs who are undergoing low or intermediate risk surgery do not require additional preoperative studies. Okay. Understood. So patient having chronic renal failure, stage 1, 2. Okay, and his functional meds also greater than 4. Okay, then no workup needed. Okay. So suppose the patient having 3 or 5, CRF stage 3 to 5. Okay, then they should receive the additional cardiac imaging, other investigations they needed. Okay. This is important. Okay, CRF 1 to 2 and functional status more than 4, no need for any further investigations. So next comes here, once the patient is stable after the operation, these medications should be received early in the postoperative period. So what they're telling is they are simply telling about the cardiac failure, that renal failure patient, what are the drugs they will take, diuretics, like the drugs. and ACRE, ARE, ARV. So these drugs, what they are telling, once the patient is stable after the operation, this medication should be resumed yearly. They should resume very early, and they didn't tell about when to stop the drug and all. That will come later. Okay. And the hepatobiliary system. Then we'll go to the hepatobiliary system. So hepatobiliary system, maybe they are concentrated about. This is a surgical risk score. We already know CTP score. Okay. So they are telling about 3 scores only: CTP, MELD, and residual liver volume. Okay. And the CTP, what is CTP child book score? Oh, for initially, child book score was identified for identify the risk of post-systemic channeling for various cell bleeding. It's already asked me in MCQ. Okay, why MELD is, anyone could say for what purpose MELD was discovered initially?
Tips success. Right. Yes. Outcome of the tips.
Tips. Very good. Okay. So MELD for tips, and it's a CTP score. They are telling that. So you know CTP score 5 to 6, 7 to 9, and 10 to 15. Okay, ABCD. Okay, these are already known points. Now the new point added in the resistance 20 of steady is resistance 20 of steady in CTP score is this we want a mortality rate. Okay, mortality rate for ABC 10, 20, 60. Remember 10, 20, 60. Remember. Okay, then come to your MELD score. The MELD score already know the mnemonic CVI. Everyone knows. Okay, so what is the MELD score? What is the basic MELD score? Not given in this book. Its minimal score is 4. Real score is 60. But it's saying that okay, MELD less than 8 is associated with 6% mortality, and greater than 20 is associated with 50% mortality. So less than 8, 6%, and greater than 20, 50%. Just remember. Okay. Just remember this mortality rate, that much is enough. Okay. So next comes your another term is called 50-50 criteria. Okay, 50-50 criteria post-hepatic liver failure. What is 50-50 criteria for post-hepatectomy liver failure? They will ask. This is generally defined as PPINR greater than 50% of the normal. That means that INR more than 1.7 and serum bilirubin more than 2.9 milligram per deciliter. That means that in milligram that is 2.9 milligram and the microgram 50. Okay, here comes your first 50 PPINR and second 50 in bilirubin on post-operative day 5. It's not 50, it's 5. It is referred as 50-50 criteria for post-hepatic liver failure and is associated with again 50% of mortality. So once I am telling, so PT more than 50%, serum bilirubin more than 50 micromole, and post-operative day 5 it is associated with up to 50% of mortality rate. Okay, that is called 50-50 criteria for post-hepatectomy liver failure. So after hepatectomy, if you see these lab values on these days, is associated with 50% mortality rate. This is called 50-50 criteria for post-hepatectomy liver failure. Very much expected. Recently added in revision 21st. Not in revision 2020 edition of revision. It is added in the 21st edition. So we already know the functional liver residues. Okay, functional liver volume, FLR. Okay, functional liver residues. So we already know the formula 20, 30, 40. Okay, so 20 means 20 needed in normal liver. 30% is post chemotherapy liver. Okay, and the 40% in cirrhotic liver. So this much of liver should be present. Okay, while doing hepatic resection to prevent the patient from hepatectomy failure, post hepatectomy liver failure. Okay. So remember 20, 30, 40, 20 for normal, 30 for post chemotherapy, 40 for cirrhotic patient. So hematological system. So let's come to the hematological system. The hematological system. So what are the most common adverse events? Okay, following transfusion of RBC. So most common is 1 in 60 you have to see. It's a febrile reaction. Okay. So actually it is a hemolytic febrile reaction, but they are given febrile reaction as well as febrile reaction. So anemia. So anemia is anemia. Anemia is the chronic anemia is one of the most common finding. Okay. On routine preoperative evaluation. So what to do with anemia? When to transfuse? That everything you will see now. So hemodynamically stable patient. Okay, hemodynamically stable patient and the asymptomatic hospitalized patient, and transfusion is not indicated until hemoglobin level is 7. So cutoff level is 7. If it is 7, leave. If it is below 7, then you can give transfusion. That is they are telling in case of hemodynamically stable, asymptomatic, and transfusion not indicated. Okay. And then suppose what the 2 trial here, actually 3 trial is included in the anemia. It's very important. The 3 trial, you should know about the 3 trial. What is trick trial, what is risk trial, and the focus trial. So this 3 trial is very important. The trick trial, just remember this, no need to go deep. Just remember the trick trial is for critical care, transfusion requirements in critical care. Okay, that is enough. And the risk trial is for transfusion requirement in septic shock. That only they will ask. Okay. Okay. And that another see that potential exception to the 7 gram transfusion, the threshold include a patient with cardiovascular disease, number 1, and those having cardiac surgery for whom a transfusion threshold is 8. Okay. So one of those who is planned for cardiac surgery, you should not keep the threshold as 7. You can give this threshold as 8. Okay. That is another MCQ. So next is your focus trial. So what focus trial is telling that is a transfusion threshold of 8 gram per deciliter is not associated with the worst postoperative outcome when compared to a threshold of 10 gram per deciliter. Okay. Transfusion threshold of 8 gram per deciliter is not associated with the worst postoperative outcome when compared to threshold of 10 gram per deciliter. Okay. Understood as self-explanatory only. Okay. Mainly there are 4 MCQs. Okay. The 4 MCQs in you can say 5 MCQ also. Okay, tricks also you can see. Tricks 3 trial. Okay, it's mainly for cardiac surgery. Okay, cardiac surgery. So not what they're telling that they're increasing the threshold. Okay, of 7.5 and 8.5 to 9.5. Okay, in cardiac surgery patients. Okay. So the first MCQ is the most common finding on routine perioperative evaluation is chronic anemia, not acute anemia, chronic anemia. Second is 7 gram per deciliter in asymptomatic normal patients, and the trick trial and the test trial. Then where you have to be 8 for cardiac surgery, it should be 8. And what is the tricks trial? Okay, for cardiac surgery. Then focus trial regarding about telling about the post-operative outcome between 8 and 10. Okay. So what is inherited coagulopathy? Inherited coagulopathy, they are telling some words that spontaneous bleeding generally does not occur unless patient blood count is below 30,000. First MCQ. In inherited disorders, inflated function of storage in storage disorders include von Willebrand diseases is the most common. Okay, they are divided into the inherited diseases and the acute diseases. The inherited disease, von Willebrand diseases is the most common. The acute cases, many causes is there: platelet dysfunction, including cirrhosis, myelodysplastic symptoms, uremia. Yeah, many causes are there. No need to go all the causes. Okay, so what are the isolated prolongation of APTT? Everything it come under this flow chart. Okay, suppose the patient comes with the bleeding, you have to go to the screening studies, which includes PT, PTT, bleeding PFA. If you have to see the PT, PTT, only PTT only prolonged. This can ask us MCQ. It is a factor 8, 9, 11 deficiency. PT only increases, then it is 7 only. Okay, both PT and PTT prolonged, then means that it is common pathway, it is not the common pathway, then it is 5 and 10. Okay, 5 and 10, both means 5 and 10. Okay, deficiency. So loop plus anticoagulant screen will be seen in mixing studies. Okay, so this is a PT abnormalities. If there is no abnormality, then you have to go for 13 assay, factor 13 assay, and consider rare fibrinolytic disorders and evaluate for connective tissue disorders, child abuse. Okay, if you have to see normal CBC blood count and the blood bleeding time and the PFA. Okay, so PFA is platelet functional assessment. Okay. So background noise and okay. So suppose von Willebrand disease you have to identify, you have to see about von Willebrand antigen should be present. Okay, other factors such as von Willebrand RCO. So RCO means was risk of seeping cofactor. Don't be that much deep, and factor 8. Von Willebrand multipliers and RIPA. RIPA is resource reduced platelet aggregation. If you are this person, then we will go for 1 milligram diseases. If the platelet disorder is there, then you have to see whether congenital or acute, and we will go according to that. Okay. Other platelet studies you have to do, and you have to see. The main thing MCQ crack is here. Okay, this thing they will expect. Okay. So these are the diagnostic things only, and how to manage these things is very important for a surgeon. Okay. So if you identify it is a hemophilia A. Okay. So what is the difference between hemophilia A and B? Is hemophilia A is factor 8. Okay, and hemophilia B is factor 9. Okay, this is a deficiencies. Okay, and see here, if it is a hemophilia preoperative, this is a treatment of hemophilia A depends on the disease severity. So if it is mild disease, okay, mild disease means how when to say mild disease means when the factor 8 is more than 5%, and it is very mild and it's respond well to DDAP. DDAP means you are vasopressin. Okay. Okay. So like that hemophilia B, even mild forms may require factor replacement. Okay. It is because factor 9 does not respond to DDAP. Even mild form of hemophilia B require factor replacement. Okay. So hemophilia B will require factor replacement, not DDAP. Okay. Both before and after major surgeries. Okay. Let's remember hemophilia A, DDAP, hemophilia B, face factor replacement. Okay, mild forms. These are mild forms. Okay. Up to 20% of patients with the severe hemophilia will ultimately develop inhibiting antibodies to factor 8. These are the facts, some facts. So what about the von Willebrand diseases? Von Willebrand factor deficiency will lead to von Willebrand diseases. The von Willebrand diseases having two types, type 1, type 2. The type 2 again divided into 2A, 2B, 2M. Okay. So this most common type, the most common type is the type 1, and it is respond well to DAVP. Okay. When you have to admit DAVP, that is another MCQ, that 1 hour prior to incision. Okay. These are the scenarios they will ask in cases. A patient comes with the type 1 von Willebrand diseases. Whatever prior to incision, we do the DDAVP 1 hour, 2 hour, 3 hour, 4 hour. So the answer will be 1 hour. Okay, 1 hour prior to incision. So what is the type 2 von Willebrand diseases? It's already having this variety of qualitative defect in the von Willebrand factor. The result decreased binding of factor 8 and the result platelet function. That is 2A-B-M. Okay. Okay. So DDAVP will include a partial responsive patient to type 2A and M. This is von Willebrand disease. It is contraindicated in type 2B, as it causes thrombocytopenia. Okay. So 2A and 2M will minimally respond to vasopressin, but 2B it is contraindicated. That is a MCQ. So where is vasopressin is contraindicated in von Willebrand diseases type 2B. Okay, and another one type is called type 3. It's a complete and near complete deficiency in the von Willebrand disease. Universally does not respond to DDAP. It will not respond. Okay. So contraindicated in type 2B, and it will not respond in case of type 3. So for all patients with the type 3 von Willebrand disease and most patients type 2 disease, von Willebrand constant is the treatment of choice. Okay. So then what we should give? It will not respond to DDAP also. Then what the drug we should give is, we should reduce the factor, von Willebrand factor concentrate. Okay. Simply I'm telling von Willebrand diseases 3 types, 1, 2, 3. So 1 will be most common. It will respond to DDAP 1 hour prior to the incision. And the type 2 having A, B, M. Okay. And A, B, A and M. Okay. A and M are partially respond to vasopressin. And the 2B is contraindicated for vasopressin. And the 3, okay, 3 is also not responding to DDAP. So for 3 and some part of von Willebrand disease 2, you have to give 1 factors. Okay. So antiplatelet therapy. So this again they're telling that is another important MCQ. Recommended levels of von Willebrand factor in patient with von Willebrand disease selected for surgery. So suppose the patient is selected for major surgery. Okay, you have to give 100% von Willebrand factor. Okay, daily. Standard throw daily levels of 50% until the wound healing. So first preoperatively you have to give 100. Okay, and daily you have to give 50% till wound healing. That means 5 to 10 days. In the minor surgery, 60% you have to give preoperatively and 30% until wound healing. Okay. So dental extraction, very important. So dental extraction, only single dose only. Single OD dose, 60%. Okay, and in case of delivery and periperium, you have to give 80 to 100% pre-delivery and 30%. So everything minor delivery periperium and all, you have to give 30% pre or post-operative. Only in major surgery, you have to give 50% thoroughly in post-operative. Okay. Just remember this thing. This is very important. Okay, then for urgent operation 4 weeks after bare metal stent for DS and should be continued. So here, so let's come to the antiplatelet therapy. So antiplatelet therapy, they are telling that elective operations that require discontinuation of dual antiplatelet therapy should be avoided within 30 days after the bare metal stent and within 12 months after a DES. Okay. Okay. So the same thing where we already saw. Okay, 1 month for BMS and 1 year for DES. Drug-eluting stent. Okay. You should avoid the surgeries. And if suppose urgent operation within 4 weeks after bare metal stent or DS implementation, and dual antiplatelet therapy should be continued. Okay. For urgent operation within 4 weeks after bare metal stent or DS implementation, dual antiplatelet therapy should be continued. Okay, unless there is significant risk of life-threatening surgical bleeding. Okay. So here that another term they're telling that discontinue P2Y2 inhibitors therapy during this time. Okay, and aspirin should be continued and the PYT inhibitor should be restarted as soon as the post-operative. So anything they ask about the P2Y2 inhibitors. Okay. It's a mess. Okay. So you have to start your dual antiplatelet therapy within 4 weeks. Okay, after doing any major surgeries. Okay, and if suppose what about P2Y2 inhibitor, Y12 inhibitor is okay, you should discontinue during the surgery. By the time aspirin should be started, and you should start the P2Y2 inhibitor immediately after the surgery. Okay. So they didn't mention about how many weeks before you have to stop your P2Y12 inhibitor. They didn't mention here. Just to see here. And what is POISE-2 trial? Very important. The POISE-2 trial, the landmark trial. Okay. The POISE-2 trial is for antiplatelet therapy. Just remember that is a main important sheet. It's mainly for antiplatelet therapy. It's concluded that administration of aspirin in the perioperative setting has no impact on death or MI and increases the risk of major bleeding. Okay, that is a POISE-2 trial. So we have seen many trials in this one. So the main important is POISE trial because it is a landmark trial. It's still about the aspirin in the preoperative setting has no impact on death or MI. It is the risk of major bleeding. Okay. Then anticoagulation. This anticoagulation very much explained daily actually. Anticoagulation, what they're telling is patient that expression high risk for thromboembolic complications. So these are the patients which is high risk for thromboembolic complications. Who recent MI, recent ischemic stroke, inadequate coagulation setting of ARTF fibrillation with the CHADS to VASC. This score is means we will see in daily. Okay, what is this explanation? Okay, CHA2 DS2 VASC greater than 1 should not undergo elective operation until clotting is optimized. So these are the patients. Patients should not undergo because they are high risk for thromboembolic complications. Recent ischemic stroke and inadequate anticoagulation setting of atrial fibrillation with this CHAD-VASC greater than 1. Okay. So let's come on about the different what are the different antivirals they are using? What are this half-life INR and where should it be used and where should not be used and how many hours it should be stopped? So everything is very important in this trial. Okay. So before they are given in sorry. So they are given this table column. Okay, table 10.9 oral anticoagulants. So they are giving about all the drugs: warfarin, dapicarban, rivaroxaban, amixaban. Okay. So we have to see about what are the mechanism of action, what are the how to monitor these things, and the clearance and the onset. Okay. Half-life you have to see about, especially you have to know about warfarin. Okay. Warfarin. So preoperatively how much days it should be hold and post-operatively when it should be resumed. Okay. And what is the reversals? This table column is enough. Okay. So you have to remember that this warfarin is a little bit different. That's not the same. So half-life of warfarin is 1.5 days to 2. Nearly it's 2 days. Okay, 1.5 days to 2 days. Remember like that. And the pre-operative hold 5 days before the surgery. You have to hold for 5 days, and the post-operatively within 1 day you have to start again. Okay, and the reversal PCC. What is the reversal agent for warfarin is PCC, FFB, and vitamin K. Okay. Okay, so that is finished and dabigatran. So rest dabigatran, rivaroxaban, amikexaban, everything you have to stop before 2 days, and you have to start after 2 days. Okay. So our expected MCQ is what is the reversal agent for dabigatran? Newly added in a new semester. So idarisumab. Okay, this is a idarisumab, and rivaroxaban and amikexaban. We have to. This also new. It's an adinexanate alpha. Andexanate alpha. Okay. Andexanate alpha. The same word amikexaban and rivaroxaban. Rivaroxaban, amikexaban. Okay, this one with these 2 terms. So the same thing they have told inside the theory also. So warfarin half-life they told the continue and stop before 3 years, and you should properly check for the INR. Okay. So restart the warfarin within 24 hours after surgery. Okay. And they're telling about the bridge trial. The bridge trial they're telling that you have to bridge the, because if you stop the warfarin, it will take almost 4 to 5 days. Okay, to act on the blood. Its half-life is like that. Okay, so that you have to in between you have to give a bridge with the low molecular heparin. Okay, the bridge trial concluded that the foregoing bridging with the low molecular heparin in the setting does not increases risk for arterial thromboembolism and decreases the risk for major bleeding. Okay, when used in the setting of bridging treatment, unfractionated heparin should be stopped 4 to 6 hours before surgery, and low molecular heparin should be stopped 24 hours before surgery. For operation with high risk bleeding, therapeutic low dose thromboglycans should be resumed 48 to 72 hours post-operative. Okay. That's about bridge trial. Then that about dabigatran. Okay. So dabigatran already saw inside that one. And you have to know about what is a CYP34. This is a rivaroxaban. Okay, this rivaroxaban, amikexaban, endotoxaban, betiroxaban, direct 10 inhibitors and all. CYP3A4. Okay. What are the cytochrome 50 inhibitors? The basic question, pharmacology question, ketoconazole, amidazole, cimetidine. Inducers means carbamazepine, pentine, rivaroxaban. So one drug is there. What is it doing is it inhibit both CYP3A4 also and P-glycoprotein also. What is the drug name is called? It's called ketoconazole. Okay, ketoconazole having anti-ovulation effect. Okay, that you should know. And what is the reversal agent for oral renin inhibitors is called andexanate alpha. That is recently FDA approved 2018. Okay, andexanate alpha. Then go to endocrine system, diabetes mellitus. The diabetes mellitus, what are the drugs we are using is short-acting insulin only mainly we are using. That is also short, intermediate, long-acting insulin. Okay, so long-acting insulin, they didn't tell about any particular protocol. They tell that should be administered as scheduled during the perioperative period. Okay, so intermediate-acting insulin, that is NPH. Okay, NPH, they are telling that it should be administered 1/2 dose on the morning of the surgery and resumed at the normal dose once the normal data has been resumed. So half the dose you should be given for intermediate acting insulin. Okay. On the morning of the surgery. Okay. But in case of short acting insulins, okay, short acting insulins and intermediate with the short acting insulins, okay, are generally held and not administered during the morning of surgery. Okay. When you are giving short acting or intermediate with the short acting, anything you should not give on the day of surgery. Okay. Morning after surgery. Only you can give intermediate acting NPH. You should try only half dose. Okay. And what about the other oral lipoglycemic agents? Insulin we are asking oral lipoglycemic agents, sulfonylureas. So sulfonylureas to be withheld during the rest you can take with surveillance to be withheld. Okay. And the DPP inhibitors. Okay. The patient should be taken DPP administered. They should take. So sulfonylureas they will not take, and DPP inhibitors they would take. What about metformin? So metformin, many controversy is there. But finally, they are telling that so metformin you can take. Okay, continuing the metformin to the day of surgery, including perioperative glucose control. So sulfonylurea you should not take. You should withhold, and the DPP-4 inhibitors like leptins can be administered. Okay, this can be administered. Metformin should be administered. So what is hyperthyroidism? That hyperthyroidism. What to do? We have to typically suppress perioperatively in case of thyroid surgery. Anyway, in thyroid surgery, before doing our thyroid surgery, we will decrease the thyroidism. Okay, hyperthyroidism. In non-thyroid LLP operation, what to do? Should be delayed until hyperthyroidism is addressed. And their hypothyroidism, what the rule? Hypothyroidism, what the rule means? Okay. It's hypothyroidism with the indolent chronic disease, and patient with the asymptomatic hypothyroidism can be started on thyroid replacement hormone at any time during the perioperative care. We can start thyroid replacement hormone at any time. Okay, in case of hypothyroidism. But the hyperthyroidism, you should decrease the thyroid. After that only you go for surgery. That is a rule. But hypothyroidism, we can start thyroxine replacement anytime. So that is a law. So adenocortical symptoms. So many adenocortical symptoms are there. So you have to rule out these things. Example, pheochromocytoma, functional adenocortical carcinoma, functional paraganglioma. So many things are there. In that, urgent operations without sufficient adrenal blockage should be avoided. Okay. So you should, if adrenergic stimulation is more, you should block the adrenergic block. Okay, you should block the adrenergic stimulus. Otherwise, the patient will go for multiple symptoms. Okay, so in emergency surgery, you should go with sufficient adrenergic blockade. Next thing they are telling that what are the things in case of adrenal insufficiency. Suppose the patient having adrenal insufficiency, the patient should be given glucocorticoids. Okay, so you should not give high dose steroid replacement as we use in steroid baseline. So nowadays they told that high dose is not necessary. Okay, so they are using the low dose steroid. Okay, the patient with higher daily dose of glucocorticoids can be tested for. Suppose you are giving high glucocorticoids, you should check for the HPA suppression. Okay, HPA suppression to steroid is with low dose adrenocorticotropic hormone. So low ACTH. You have to give low dose ACTH to check for the HPA, hypothalamic pituitary axis, whether it is secreting steroid or not. Then only you have to give steroids. Okay, so for that the test is called co-syntropin test. Co-syntropin stimulation test means by using ACTH, you are stimulating the hypothalamus pituitary axis for the secretion of steroid. Okay, for checking. Okay, that's the thing. In that, they're telling one table is very important. Perioperative supplemental glucocorticoid regimens. Okay, how to identify? Suppose the patient having no HPA suppression. How to identify they are not having any HPA suppression means? So less than 5 milligram of prednisone. Okay, for any duration. For any dose, they are giving an alternative single morning dose of short-acting glucocorticoid of any dose duration, or any dose of glucocorticoid for less than 3 weeks. Okay, if like it is there, still the HPA suppression is not happened. So for that patient, the treatment is give usual daily glucocorticoid dose during perioperative periods. Okay, you understand? And the HPA suppression documented or presumed. Okay, when the HPA suppression is documented, okay, and you are suspecting very highly, that means that when the patient is taking more than 20 milligram of prednisolone for more than 3 weeks, okay, or when the patient getting cushinide appearance, and when biochemical adrenal insufficiency and in low dose ACTH stimulation test, that is post-syntropin test. Okay, so post-syntropin test is positive, already the HPA suppression happened. Okay, for that patient, what is the dose of steroids? That is your MCQ. Okay, so for minor procedures, okay, give usual glucocorticoid dose, finished. For moderate surgical stress, okay, for the moderate surgery, you have to give 50 milligram of hydrocortisone IV for andexanon anesthesia, 25 hydrocortisone every 8 hours. Okay, then usual dose. So for major surgical stress, you have to give 100 microgram of hydrocortisone. Okay, and 8 milligram hydrocortisones thereafter. Okay, just remember these terms. Okay, how to identify. Here any dose of glucocorticoid less than 3 weeks. Okay, then here it is more than 3 weeks. And HPA suppression when it is uncertain. Uncertain means when in between 5 and 20 milligram are equal to more than 3 weeks, and more than 5 milligram prednisone equivalent for more than 3 weeks. 3 are equal weeks. Okay. So next thing is nutritional obesity. The nutritional obesity preoperative nutritional assessment by using nutritional risk screen tool NRS 2022. Okay. So what is the most indicator, serum indicator using is albumin, pre-albumin, and transferrin. So each having its certain MCQs. So albumin is generally reference indicator for chronic nutritional status. So albumin is for chronic nutritional status, and pre-albumin reflect recent nutrition. Okay. So why? Because the albumin's half-life is 20 days and the pre-albumin half-life is 2 days. Okay. But these both are negative acute phase proteins. Okay. When it is when there is more inflammation in the body, and it results in decreased levels of both albumin and pre-albumin, thus making it less reliable. So that it is very less reliable in the perioperative settings. Okay. Just remember all the MCQs. Albumin is for chronic, and pre-albumin is for acute. You can transferring half-life is 8 to 9 days, and it having even though it is a negative acute phase reaction, transfer levels must also take into account the serum iron levels also. Okay. It also takes serum and iron level also. Transferring don't have that much importance, but you have to remember about albumin and the pre-albumin. Okay. And the nutrition supplementation. So they're telling that parental nutrition frequently lacks immune bolstering glutamine and omega-3 fatty acids, which support the GAT, important immunological functions. For GAT, glutamine is very important, and omega-3 fatty acids is very important. So many nutrients they are telling that, and the NRS 2002 data, what is telling that a screening tool and considering parental enteral pre-ovulation of patient with severe malnutrition. Okay, this is related to parental enteral pre-ovulation. NRS 2022 is related to nutrition, especially parental enteral rehabilitation for severe malnutrition. Okay, the ERAS protocol, what is telling that the early enteral nutrition within 24 hours is a key component of the most enhanced recovery after surgery. Okay. Then this is NRS 2002 tool. Okay, nutrition risk screen tool. Here they are having 3 scores. Okay, actually 4 scores: 0, 1, 2, 3. Okay, based upon the impaired nutrition status and the severity of the disease. Okay, based upon this, the score will changes. So just remember these things enough, and this impaired nutrition status you have to know, and the severity of the disease you have to know, and what is score more than 3. The score more than 3 means the nutrition at risk, and the score less than 3 is a rescreening of the patient, weekly rescreening of the patient. Okay. For example, the patient is scheduled for major operation, a preventive nutrition care is considered to avoid associated risk status. But remember this term: more than 3, less than 3. Okay.
Nutric score. What mnemonic?
What?
Nutric score.
Nutric score.
Dance. DANS. Dance. Cutoff is 5.
Cutoff is 5.
If interleukin is added, cutoff is 6.
6. Right. So regarding come to obesity, esteems of obesity is greater than 40 or less than 18 associated with the surgical morbidity. Okay, and the postoperative morbidity. So AHA recommends, okay, preoperative ECG, okay, sesquitergain for all patients with BMI greater than 40. Okay, who have a risk factor for heart failure or excess tolerance. So remember that more than 40, they're asking other ECG, sesquitergain. Okay. Okay. What is obesity paradox? That is very important. Our mildly elevated BMI 25 to 30 may actually be associated with decreased morbidity and the mortality, a concept commonly considered obesity paradox. Even though they are obese, they are having decreased morbidity. Okay, that is obesity paradox between 25 and 30. So obesity paradox is 25 to 30. Okay, and the AHA, this BMI criteria is more than 40 for other investigations. All are terms, and you have to remember again you have to read. So this everyone knows only classification and all. The ERAS classification they are telling here. They are telling that the protocol means ERAS protocol only. They are not explained very well here. Okay, I will tell in another slide. And what is about antibiotic prophylaxis? Antibiotic prophylaxis, superficial infection means only skin and subcutaneous, and deep infection means fascia and muscle. So two of the simplest actionable measure that reduce the risk of SSI. What are the two? One is perioperative antibiotics, and the second is administration of antibiotic within 1 hour of injection. So first one is appropriate antibiotic is needed. Second thing is appropriate time also is important. Okay, this both of the things is reduces the surgical site infections very quickly. So one classification. Then you have to see about they are telling about clinically they are using many antibiotics for many purposes. For most operations they are using cefazolin. Okay, that's remember cefazolin. And regarding the timing of the operation, many controversies are there, but the recent data support that administration of first dose of prophylactic antibiotic within 60 minutes before surgical incision. Okay, clear, Sebastian. Okay, 60 minutes before surgical incision. Okay, for suppose some antibiotic will require longer infusion times. Example, vancomycin fluoroquinolones that begin within 20 minutes before incision. Okay, 2 hours. Vancomycin fluoroquinolones 2 hours. Normal antibiotic 1 hour before incision. It's not at the time of induction of anesthesia. Okay, not giving incision. Yeah, sorry, it's the time of giving incision. Okay, surgical before surgical incision. Not at the time of incision, not at the time of induction of anesthesia. It's before surgical incision. Okay, and when the redosing of antibiotics is needed. Okay, the redosing of antibiotic needed when maintain the serum therapeutic serum level generally after every 2 half-lives, or if the blood loss greater than 1.5 liter. Okay. So most clean and clean contaminated operations do not require post-operative antibiotic and administration. There is evidence that the antibiotic duration up to 48 hours reduces the risk of standalone infection. Consideration of antibiotic maintenance up to 48 hours after cardiothoracic surgery. Only for cardiothoracic surgery, they are telling to give antibiotic up to 48 hours because it reduces standard complications. So review of medications in the cardiac and inhalers should be continued on the morning of the surgery. Just a fact that the cardiac drugs and the inhalers should be continued on the morning of the surgery. So next, the telling about the estrogen, this herbal medicine, vitamins, oral contraceptives, hormone therapies are underreported, still underreported, but they're giving some values for estrogen tamoxifen is to be stopped before 4 weeks. Okay, and herbal medicine is variable. This herbal medicine, they can ask us MCQ. They gave a nice flow chart for herbal medicine when to stop. Okay, so see. So preoperative table 10.14 preoperative recommendation for herbal medicines. So you see many herbal medicines are there. Among that you see which should be stopped before 24 hours. You have to stop kava and ephedra. Okay. Okay. EK. You have to stop for 24 hours. Kava and ephedra and garlic ginseng. More like that. Garlic ginseng. Okay, garlic ginseng, you have to stop 7 days. Okay, you have to stop 7 days before 7 days. Okay, and only gingigo is at least 36 hours. Okay, and the main thing is Saint John wort. So Saint John wort, when I have to stop, see yes is like 5. Okay, 5 days, at least 5 days before surgery. Okay, Saint John's wort. Okay. Just remember these things. Just coming back to our chapter. Estrogen tamoxifen 4 weeks and herbal medicine to days to already saw the herbal medicines. It's on the page number. We are now in the page number 208. Okay. So next about the preoperative fasting. The fasting they're telling that clear fluids 2 hours. Okay, breast milk 4 hours, light milk 6 hours. And separate table column is there for this. No need to read these recommendations and all. Okay, I think waste of time. You can, if you want to read, you can read this thing. These 3 they can ask us MCQ. What are the oral antibiotics for colorectal surgery prophylaxis? Okay, used in conjugation with mechanical bowel preparation. One is erythromycin base, and number 2 is metronidazole, number 3 is neomycin. Finished. So this I already told for herbal medicines. And again, recommended minimum fasting period for Arctic, very important. Okay. So what is clear fluid? 2, breast milk 4, infant 6, non-human milk 6, light milk 6, and fried food or meat 8. Okay. So remember like a CBI. Okay. NLF. Anyway, you have to remember. Okay. Okay. So 2, 4, 6, 8. Next comes your next. It will be your preoperative for next. Come to operating room. Operating room. No much MCQs. I have heard that best practices uses closed loop communication techniques to ensure communication is heard, understood, and acknowledged by the all parties. So remember that closed loop communication. And the second is the maintenance of normothermia. How to maintain normothermia? We already saw in chapter 2, but again they are telling that. Okay, yeah, they're telling that risk of hypothermia is increasing. Risk of page number 212. Okay, page number 212. Risk of hypothermia increasing elderly female malnourished patients. So this is very important MCQ. So what are the best and most pragmatic monitoring site for hypothermia is temperature monitoring is distal esophagus for intubated patients. Very important. So distal esophagus for intubated patients the most best site for monitoring for temperature. Distal esophagus for intubated patients. Okay, and what about the sublingual axillary? Okay, and the bladder temperature also correlate with the core body temperature. Okay, it's also correlate, but the best is distal esophagus in case of intubated patients, and the sublingual axillary and the bladder and all also correlate core body temperature. So which of the following area will poorly correlate with the core body temperature? Skin, forehead, external oral canal, rectal temperature. They can ask MCQ like this. Okay, so rectal temperature is poorly correlated. Okay. So next comes your so then how to rewarm the patient? The rewarm the patient using passive insulation. It gives only 30% of the heat loss, and active warming. Active warming with the forced air is the best, most common approach due to ease of use and effectiveness and low cost. So, and when you are giving more amount of fluids and more than 1 liter, it may cool the patient. So what they are telling that if you are going to give fluid more than 1 liter, you have to intraoperative infusion of 1 liter should be pre-warmed. You should warm the fluid and you should give. Okay, so again I'm telling. So what is the best site is a distal part of the esophagus in case of intubated patients, say sublingual axillary, and the bladder temperature also correlate. And to passive warming only 30%, active warming, especially forced air is a good common approach. And more than 1 liter giving fluid, it should be pre-warmed. So what is the preoperative skin incision? And they're telling that SSI compression more than 20% of hospital active inspection. So CDC guidelines. What is the CDC guideline? What they're telling is 1, 2, 3, 4. But they are telling that how to antiseptic technique, how to use that wide area to include many potential sites and the concentric circular motion. Okay, while draping and all, they are telling that in the circular motion. Okay, and use dedicated application instrument and the adequate time to allow solution to dry. Okay, these 4 are the CDC guidelines. This can also ask MCQ. And hair, when to remove the hair removal. Okay, prior to incision can improve exposure and allow skin marking. So prior to incision they are telling, and using with the clipper. Okay. Hemostasis, they are telling the hemostasis. They are telling that when to use monopolar cautery. Suppose vessel is bleeding. So this is a nice MCQ. When to use monopolar cautery, when to tie, clip, staple, or bipolar cautery or ultrasonic device, and when to go for suture ligation. Suture ligation also you could do for certain condition. First we will see capillaries and small veins or monopolar cautery should be used, and the vessel more than 1 millimeter in diameter, including all named vessels. Any named vessel is there, you can go for other measures, tie some bipolar ultrasonic devices. But okay, in case of large vessels, you should not tie or clip because it may go for slippage. Larger vessels, in larger vessels, you can go for suture ligation. And the wound closure, they are telling that permanent suture we can use the fascia. So fascia we are closing with anything. You can use PDS also. You can use nickel also. So when to use permanent, when to use permanent, when to use dissolvable. So they're telling that permanent suture is best. Okay, best for malnourished patients, debilitated patients. Okay, and for scenarios in which yearly follow-up is anticipated. Okay. For malnourished and debilitated, they are using telling to use permanent switches and dissolvable switches like previous victory and all. Used in subcuticular layer, and they often create a cosmetically appealing closure that does not require suture removal. Thus, they are telling permanent suture is best. Remember this term: permanent suture is best suited for malnourished and debilitated patients. And delayed closure. Delayed closure is commonly attempted between 2 and 5 days. Okay. We already know what is a primary closure, delayed closure, and all. So delayed primary facial closure. What is the dates? How many days? Delayed primary facial closure. That means that it should be achieved within 7 to 10 days. Okay. If it is not possible to do this delayed primary facial closure, one patch is there. That is name is called Whitman patch. Newly added section 21. Whitman patch. What is Whitman patch? Is if you apply this patch like this, and daily you have to adjust. Daily you have to adjust, and you have to close. Okay, like this one patch. Okay, Whitman patch. It's tightened every 24 to 48 hours. So next is surgical adhesives. The most common adhesives are dermaband and the histoacryl. Okay, dermaband and the histoacryl. Okay. And fibrin agents, where they are using fibrin agents in perineal fistula they are using, and bronchopleural fistula they are using. And the next to come to your electro devices. So electro devices, monopolar electrosurgery. So continuous waveform is cut and intermittent waveform is coagulation, and one more waveform is there. It's called blended waveform for blend mode. Okay, and the bipolar basics and all everyone knows. This end artery should not use everyone knows that I will not repeat. And the ligasure or NSIL up to 7 mm vessels will see. And one more is called saline cooled radio frequency dissectors. Saline cooled radio frequency dissector. Okay, it's using the radio frequency only. But what is the disadvantage of this dissector is it will cause dense eschar that limits the coagulation and may result in delayed hemorrhage. So expected MCQ. Okay. What are the most common complication of saline cooled radio frequency dissectors? Okay, delayed hemorrhage. Okay, and maintaining and one more thing is that the saline cooled radio frequency dissectors overcome this issue by directing a steady integration stream of saline to the issues conductant, thereby maintaining surface temperature less than 105 degrees Celsius. So to prevent this eschar only, they are making the self saline cold, okay, and making the temperature less than 105 degrees Celsius. So where they is using this commonly using this device is dissection of solid organ parenchyma such as liver or kidney. Okay, where is ultrasonic dissectors? That ultrasonic dissectors, the new dissector. There we are using is this. Okay, shock wave lithotripsy is effectively primary for smaller stones with the lower radiographic in. Okay, with the low radiographic density. So like like ESWVL in a renal stone, we can use this. Okay, for polylithiasis also. Okay, ultrasonic dissector. And harmonic scalpel. The harmonic scalpel having high energy setting in rapid cutting, low energy setting promote coagulation. So high energy for cutting, low energy for coagulation. In case of a monopolar continuous waveform is cut, intermittent waveform is coagulation. In case of harmonic scalpel, high is for cut, low energy is for coagulation. So what is Tusha? So Tusha we already know we use for liver resection, hepatocytes. Okay. Based upon the oscillating movements, it will do it resection. So caviton ultrasound suction as Tusha provides a precise dissection plane through this fragmentation process, but that does not confer any self vessel sealing capacity. So important, all of the properties are not present in all of the following properties are present in the Tusha as expert their loss. It is not having vessel sealing capacity. Okay. Tusha not having vessel sealing capacity, and then ablation techniques, radio ablation frequency, you know about the basics and all. So we are telling this RFE as a similar mechanism as electrosurgery, as a grounding pad is necessary. See, governing parameters says the presence of implantable electronic devices or metallic surgical clips may be a contraindication. Okay, if you are having any electronic devices or metallic surgical clips, okay, then radio frequency ablator is a maybe contraindication. Okay, so till what size of the tumor it will be very effective, up to 3 centimeter. Additional margin of 0.5 centimeter healthy parenchyma beyond the target lesion should be ablated to ensure complete ablation of the tumor. So up to 3 centimeter is very important, and the ground pad is present. Okay, and the contraindication is metallic clips and all. So same like microwave ablation. So microwave ablation is even more good. It's not here. It's in the fecal foot. It's around 5 centimeter. Okay, greater than around up to 5 centimeter microwave ablation we can do. Okay, and because the mechanism of microablation does not involve transmission of electric current, the ground padding is unnecessary. So here ground pad not there. Okay, and we can use in case of metallic clip and the implants. So these are the questions they will ask based upon this. Suppose patient having metallic clip. Okay, what are the ablation of choice they will ask. So that time microablation should be used in case of metallic clips and the implants. So next is other energy devices. They are telling that organ beam coagulator. So organ beam are not much MCQ, and the surgical staplers. The staplers they are telling that linear cutting staplers we are using for G anastomosis. Okay, and linear non-cutting staplers we are using in thoracoabdominal. Okay, it allows tissue closure without division. Only it will close and it will not divide. That is non-cutting stapler we are using thoracoabdominal. Okay. Next, your circular cutting stapler we were used for end-to-end. Okay, end-to-end anastomosis. And the smaller staplers, based upon the staple heights, the smaller stapler means it will open. This is 2 mm and this close is 1 mm. Okay, it's best for vascular. So smaller for vascular and the large stapler, open is 4.5, close is 2. Just adding and multiply it by the 2, it will best suited for stomach and pancreas. Okay. Potentially cause of intraoperative instability. What is the malignant hyperthermia? Here they're telling about some 3 to 4 pathologies. First is malignant hyperthermia. Okay, it can happen at any time during general anesthesia up to 60 minutes after cessation of anesthesia. So most common mutations, I'm just enhancing the only important points. Okay, most common mutation RO origin, autosomal dominant. Okay, up to 30 minutes during general anesthesia or up to 30 minutes after cessation of anesthesia. Okay. Okay, it's most commonly due to the mutation of RY/RM gene. It is autosomal dominant, and it is treatment is IV administration of dantrolene. So gas embolysis, embolus air access to the venous system, and abrupt decrease in the end-tidal CO2 and the cardiovascular collapse is the first manifestation. Intraoperative transhysterectomy echocardiography can help the diagnosis. Okay, and the left, what is the position? What is the best position you should keep the patient having air embolism is lateral decubitus position should only be used in the absence of cardiovascular collapse, as meaningful chest compression cannot be performed in patients who are not in supine. Okay, so see here. Okay, while the temporal lobe position may be helpful, placing the patient in the left lateral decubitus position should only use in the absence of cardiovascular collapse. Okay, if the patient has cardiovascular collapse, you should not give him left lateral decubitus. Okay, so mortality is 20%.
That is Durant position, what it is named left lateral with head low for air embolism. Durant position.
Durant, I don't know.
DURANT.
What?
Durant, sir. DURANT. Left lateral with head low position for air embolism. DURANT.
Okay.
Okay, we'll see my MI pulmonary embolism and pneumothorax. So mortality, what is the mortality in case of gas embolism is 20%. So what is MI pulmonary embolism and pneumothorax? Okay, in that telling that classical ECG changes, new profound ST elevation are the diagnostic in case of MI. Okay, and the pulmonary embolism, they're telling that in the pulmonary embolism, okay, in the absence of right heart strain, a clinical significant pulmonary embolism is less likely. With the clinical significant right heart strain, the right heart failure resulting from MI, PE, pneumothorax should be under consideration. So right heart strain is very important. Okay. The diagnosis can be made by chest auscultation, intra-abdominal inspection of the diaphragm. The patient with without breath sound and bulging diaphragm, tube thoracostomy is indicated. Okay. They are telling pneumothorax. We are in pneumothorax. Okay. Tube thoracostomy indicated. After that, we have to go for definitive elective operations. So hemorrhage, the telling that how to block the hemorrhage means you have to go for proximal vascular isolation with clamping. Okay. So when it is not possible, suppose you are doing any surgery, you have to suppose any surgery you are doing. Okay. Bleeding is coming, then you have to go proximally vascular isolation. You have to clamp any named big vessels. Okay. If it is not possible, you can go for proximal control with the supraceliac aortic compression. And directly the celiac artery itself you can compress. Like that they are telling. Proximally you have to go. Even if it is not possible, you can give a aortic clamp also. Okay. Not that much big MCQs. When OP outpatient surgery, they are telling one new term outpatient surgery for patient with AAC status 1 to 2 undergo low risk operation. Assessment may take place on the day before surgery or even on the morning of surgery. So many patients will come to our OT in the morning only. Okay, do surgery for me, do surgery for me. Like for that patient, you have to say the AAC status. You have to see. If it is 1 to 2 undergoing, the operation risk should be also low. Then only you have to take the patient. Okay. On the day before surgery or even the morning of the surgery also you can go for ASA. Okay. Physical assessment status. Then one more thing they're called super morbid obesity. Okay, with the BMI greater than 60 can be considered as an absolute exclusion. Okay, for what they are telling absolute exclusion? They absolute exclusion means this patient should not go for a operation. Okay, you see here. So now we will see who are the patients, criteria for the patients in outpatients. So obese and moderately obese patients are treated at increased risk of bronchospasm, hypoventilation, and obstructive airway, but are not strictly prohibited from obese operation. However, supermorbid obesity with greater than 60 can be considered as an absolute exclusion. So these greater than 60, they are not eligible for. They are eligible for outpatient surgery. So what are the other
not eligible for?
Not eligible, yeah. So what are the other organ specific specific exclusion criteria for outpatient surgeries are many things. Okay, you should remember this thing. It's very, very important. So when the patient has cardiac unstable angina, at risk myocardium, cardiopathy, moderate to severe heart failure, severe pulmonary hypertension, valvular disease, pulmonary non-compliant OSA, the stop bang more than 4 with anticipation for post-operative opioids, severely and poorly controlled asthma, cystic fibrosis, home oxygen use, hemolytic disorders, okay, clotting renal end-stage diseases, organ system dysfunction, dialysis, serum potassium or serum uncertain serum potassium or serum potassium more than 5.5, pregnancy specific exclusions, fetus greater than 21 weeks gestations, 21 weeks gestation. Okay, and high risk patient comorbidities such as muscular dystrophy, highly contagious airborne infection, high risk for hemorrhage. Okay, so these are the patients you should remember for this organ system specific exclusions. Okay. Okay. They will ask, suppose the patient is having chronic reflux, okay, and poorly uncontrolled diabetes. They also can be taken for outpatient surgery with the highly expertise center. Okay, not all center. Now only in the highest risk of anesthesia. Okay, only at centers with the capabilities for post-operative admission. Okay, but this you should remember. Simply should read once before going. But this is very important. BMI more than 60 is absolute contraindication. Okay, absolute exclusion. So that's it. And fast division, I will go.